And here we're going to talk about joints. So taking what we've learned about the skeletal and muscular systems over the last couple of modules, how do they work together? And this is where joints come in. So movement, the key function of our joints. So how do the muscles and the bones play a part? So let's talk about the muscles here. And we're going to take this example of a bicep curl as we're all familiar as to this action and what's involved. So here we have two muscles, the agonist or the prime mover and the antagonist, which is the triceps in this case. In order to create movement, both muscles need to change. So if the biceps contracted and shortened, but the triceps stayed the same length, we wouldn't be able to move. So as the bicep contracts, the tricep has to lengthen to allow this flexion to take place. And this is called an antagonistic pair, where one muscle contracts and the other relaxes or lengthens. And the biceps and triceps are a good example of that. We also have muscles called synergists or secondary movers that support the movement of the agonist. So they alone don't create that action, but they contract to work with and allow the prime mover to create the action required. If we take this example of elbow flexion, we have the brachioradialis, which is in the lower forearm, and we have the brachialis, which sits deep to the bicep. Both of these contract to support and work with the bicep to create elbow flexion. The other set of muscles and roles that we have are the fixators or stabilizers, and these are the muscles that stabilize the origin of the agonist and the joint. For example, in this bicep curl, this would be the rotator cuff muscles, as they are the guardians of the shoulder joint, as the muscles, including the biceps, which also cross the shoulder, create movement at the elbow. Different types of contractions. So where we have this contraction and shortening of a muscle, like we've discussed here, that is called a concentric contraction. Where we have a contraction but no movement at all, so for example in a gripping stance, we call this isometric contraction. Where we have muscles that contract but lengthen rather than contract and shorten, we call this eccentric contraction. So in this case here, we have a concentric contraction of the biceps. The tricep, if controlling the movement, could be contracting while it's lengthening, so an eccentric contraction. So how do we classify joints? Three classifications we're going to look at, first being synarthrosis, and these are immovable joints. So for example, the joints between the sutures in the skull, or between the teeth and the jaw. Diarthrosis joints are freely movable joints, and these are the joints we're more common with, so the hips, the knees, the shoulder, so where we've got lots of movement in the joint. We then finally have amphiarthrosis, which is somewhere in the middle, and these are defined as being slightly movable, or ligamentous or fibrous joints. So for example, the joint at the front of the pelvis, the pubic symphysis. So fibrous joints are defined as being fixed with no movement. There's no synovial cavity, and it's where bone to bone is joined by thin layers of cartilage. It results in a very rigid union with little to no movement of the bones, except during the growth phases as the bones grow together. And as we discussed, these sutures in the skull are a good example of a fibrous joint. Cartilaginous joints, these are slightly movable joints, or amphiarthrosis, as we labelled them earlier. And this is where, again, we've got no synovial cavity, but the bones are held together by either hyaline cartilage or fibrocartilage. So a good example of that is the ribs to the sternum. So as we have here, this is called a costal cartilage, and it allows for some, but not very much movement between the joints. Other examples are adjacent vertebra. We have intervertebral discs, and also the two pubic bones of the pelvis where they join at the front at the pubic symphysis. So synovial joints or diarthrosis, freely movable joints, and this is the most common type of joint in the body. It has a synovial cavity, which we'll look at in more detail, and it's united by surrounding articular capsule and often a number of accessory ligaments to support the joint. Given how much movement it has, ligaments are needed to provide additional support. So let's look at the different types of synovial joint. The first one we're going to talk about here is the ball and socket joint. It's a highly movable joint and it allows flexion, extension, abduction, adduction, circumduction, lateral and external rotation, or medial and internal rotation. If you're unsure of what these actions mean, I recommend you pause at this point and go and check out our video on movements of the body, so that you understand exactly what movements are available at each of these joints. So next up is a hinge joint. So we're going to look at one here, which is at the elbow. It allows movement in only one plane. So the movements we have at our elbow are flexion and extension. Other joints that are hinge are the interphalangeal joints in the hand. Gliding joints, sometimes called planar joints as well as gliding joints. Examples of this are the articular processes of the vertebrae and between the carpal and tarsal joints. It allows two planes of movement, back to front and side to side. The articulating surfaces are flat, allowing for gliding movements that are restricted by the surrounding ligaments. Pivot joints, so we're going to look here in the forearm between the ulnar and the radius. A pivot allows turning within a ring, for example, in the radio or ulnar joint. And what this allows us is pronation and supination, so that rolling over of the forearm. Condyloid joint. An example of this would be the metacarpal phalangeal joints in the hand. It is recognized by oval-shaped projections of one of the bones fitting into an oval cavity in another bone or in a condyloid. So it doesn't allow axial rotation. This is how it differs from a ball and socket joint because of the difference in shape. But it allows flexion, extension, adduction, abduction, and circumduction. And finally, saddle joints. A good example of this is at the thumb joint here. This is where the articular surface of one bone is shaped like a saddle, and the other bone fits into the saddle like a rider on a horse. So the carpo-metacarpal joint between the trapezium and metacarpal of the thumb is a prime example of a saddle joint. It allows quite a lot of rotation, but doesn't allow axial rotation. So we get flexion, extension, adduction, abduction, and circumduction. Now we're going to journey through some of the main joints of the body. And we're going to start with the spine, which is actually a collection of joints. As you can see, it is a natural soft S shape. Inward curve, outward curve, inward curve, outward curve. And this gives the spine strength. This shape gives a lot more strength and can take a lot more load than if the spine was straight up and straight down. Now let's look at the top. Let's start at the top. And this first group of vertebrae are called the cervical spine, and it's a soft inward curve or lordotic curve. It is made up of 7 vertebrae, and they start with a C, which matches with cervical. C1 through to C7. So there are 7 cervical vertebrae.
separated by an intervertebral disc. We then have the thoracic section. There are 12 thoracic vertebrae, one for each rib, 12 ribs, 12 thoracic vertebrae, and they're named beginning with a T, so to correlate with the name, from T1 through to T12. It's a kyphotic curve, so it curves outwards. We then have the lumbar spine, and these vertebrae are larger, and there are 5, starting with L1 through to L5, again separated by intervertebral discs. We then have the sacrum at the back of the pelvis, and this is made up of 5 fused vertebrae, and the coccyx, which is an average of 4 fused vertebrae. So there are 24 movable vertebrae in the spine, but you could argue it's 33 as the sacrum and coccyx are fused. So let's come back to those intervertebral discs. They're made from fibrocartilage, and they act as the spine's shock-absorbing system to protect the vertebrae and the spinal cord. The discs allow some vertebral motion, extension and flexion, but the individual disc movement is very limited. So let's talk about the movements of the spine itself when we look at those intervertebral discs, the joints and the facet joints. So let's look at it as a whole, the vertebral column. It can flex, bending forward. It can extend, opening up. We can rotate from side to side, and we also have this ability to laterally flex, so to side bend. Now we're going to look at the shoulder, but we're going to look at it in 2 parts. First, we're going to look at the ball and socket joint, and then we will look at the shoulder girdle. So the ball and socket joint is where the humerus and the scapula meet. This gives a large number of movements. It's a very mobile joint. We have flexion, extension, abduction, adduction, horizontal abduction, which is where if your arm was straight out in front of you, parallel to the floor, bringing it away from the midline, and horizontal adduction, bringing it back towards the midline. It internally and externally rotates, and also has circumduction, that full rotational movement. There are a number of key ligaments and also bursa. There's a subacromial bursa, which is located inferiorly to the deltoid and the acromion process. And there's also a subscapular one, which is located between the subscapularis tendon and the scapula, and it helps to reduce the wear and tear on the tendon during movement. Common ailments of the shoulder include frozen shoulder, rotator cuff tendinitis, shoulder impingements, and AC joint impingement. The AC joint being where the acromion process of the scapula meets the clavicle. Dislocation is another common pathology, and you may have clients with a history of dislocations. It's interesting and useful to find out what type of dislocation your client may have had. For example, anterior forward dislocation is the most common, with over 95% of shoulder dislocation cases being anterior. Posterior dislocations, these are generally due to things like electric shock or seizure, or an inferior dislocation, and this is the least common and occurs in less than 1% of shoulder dislocation cases. So as I said, here we're focusing on that ball and socket joint, but do notice that AC joint that we also mentioned. It's actually a gliding synovial joint. And again, dislocation can happen at this joint, but it's not the same as a shoulder dislocation at the ball and socket joint. AC joint dislocations are particularly common in collision sports, such as ice hockey, football, judo, etc. The most common mechanism for injuring this joint is a fall onto an outstretched hand. Let's talk about the shoulder girdle. And the shoulder girdle describes where the sternum, clavicle, and scapula work together. It's a gliding joint, and it describes that movement of the scapula against the thoracic cage. Available movements at that joint are elevation of the scapula, depression, coming down into the pockets of your jean, depression of the scapula, protraction, which is where the scapula moves around the thoracic, and retraction, where it moves back towards the spine along the thoracic cage. The elbow joint, in particular, two joints. The first, the main joint, where the humerus meets the ulna, and this is a hinge joint, hence allowing that flexion and extension at the elbow. But remember, we can also pronate and supinate at the elbow when we pronate and supinate the forearm. And this happens at the radius ulna joint, which is a pivot joint. Common pathologies include tennis elbow, lateral epicondylitis, lateral outer, so that is where the tendons on the outer aspect of the elbow joint are complaining, and golfer's elbow, which is medial epicondylitis, which is on the inside of the elbow where those tendons attach. The hip, another ball and socket joint, so allowing a large range of movements. It is where the femur meets the pelvis. Available movements involve flexion as we bend forward, extension, the opposing movement, abduction, taking that leg away from the midline, adduction, adduction, bringing it back in, internal or medial rotation, external or lateral rotation, and horizontal flexion and extension when that leg is bent to or flexed to 90 degrees, as in the shoulder movement. There are a number of key ligaments in the joint, and common ailments that you will see in clinic are things like hip arthritis, hip flexor tendon issues, restrictions in range of motion, or posterior hip pain around the sacroiliac joint, for example. The hip probably is one of the most common areas that I certainly work with in clinic. So getting a good grounding of the movements, what the movement should be in the hip, and also the soft tissues that work across this joint is really important in understanding how you can help your clients improve movement and desensitize movement in the hip. The knee joint, where the femur meets the tibia. And we also have the patella here, or that kneecap as it's more commonly known. Now, it's a hinge joint, but it's a modified hinge joint because, as well as allowing flexion and extension, when the knee is bent or flexed, it also allows a very slight rotation. Within its synovial joint, it also contains menisci, lateral and medial moon-shaped menisci, where it gets its name, cartilaginous tissues, and these provide structural integrity to the knee when it's under tension and torsion or twisting. It helps to disperse the weight of the body and reduce friction during movement. On here and here. The knee also contains bursa, fluid sacs, and synovial pockets that surround and communicate with the joint cavity. The fat pad, we have one line here. It's called the infrapatellar flat pad, and it's the soft tissue that lies beneath the kneecap. In situations where forces are directed at the patella, it can act as a shock absorber, protecting the underlying structures of the knee joint. The patella itself is a sesamoid bone, which we learn in the skeletal system module, and that is a bone that is completely embedded in tendon. The muscles of the quadriceps all blend into this patella tendon, and the patella lies within. Common ailments that you may see present are knee replacements, patellofemoral pain, Baker's cysts, Osgood-Schlatter syndrome, patellar tendinitis, and damage to the various ligaments, for example, ACL or MCL tears. In terms of the ligaments, there are ligaments within the joint themselves, the anterior cruciate ligament and the posterior cruciate ligament. And then those on the outside, medial collateral ligament on the inside and the lateral collateral ligament on the outside. The ankle joint. Two joints here. Firstly, where the tibia meets the talus. Now this is a hinged joint, and this allows for the flexion and extension that we see in the ankle. Flexion, more commonly known as dorsiflexion, and extension, commonly known as plantar flexion, that pointing of the foot at the ankle. The ankle joint also allows inversion and eversion, and this happens at the second joint where the talus meets the calcaneus. This is a condyloid joint, allowing inversion and eversion. Now, pronation and supination actually happens at the foot rather than the ankle joint. Common ailments: Achilles tendinitis, medial and lateral ankle sprains, and damage to those medial ligaments and lateral ligaments of the ankle. So the wrist, or the carpal joints. Do you remember the carpals, those square bones at the palm and wrist joint? So these are condyloid joints, and they allow flexion, extension, but also abduction and adduction. The thumb is a saddle joint, so it allows flexion, extension, abduction, and adduction. The fingers are phalanges, each one a hinged joint, allowing flexion and extension. So there's no rotation or abduction or adduction in the fingers. Toes, phalanges, the same. They're also hinged joints, and they allow flexion and extension.
So what are some common pathologies you may come across of joints at a general basis? So sprains we've just talked about, and this is where we damage the ligaments of a joint because we've overstretched them. So for example, rolling over on an ankle. We tend to get swelling in the acute phase, along with redness, pain, bruising, and into the subacute and even into the longer term remodeling phases, we can get instability in that joint, as ligaments are poor healers, and stabilization work is needed to help strengthen the supporting muscles. It's a local contraindication unless you're qualified to work with injuries. So as I said, we're not going to be working with active, acute or subacute ankle sprains or sprains of any joint. Osteoarthritis. This is where we have wearing away of the cartilage within a joint. It creates joint pain, stiffness, swelling, and even weakness. If acute and very painful, then we are not going to work on that joint, so it becomes a local contraindication. But in general, we just modify. We need to support these affected joints, as massage can help alleviate a lot of the pain and symptoms and stiffness associated with osteoarthritis. But we need to adjust our pressure and ensure that we're not inflaming, irritating, or creating instability in any joints. In the case of rheumatoid arthritis, which is more of an inflammatory condition, we get joint swelling, redness, pain, heat, difficulty in moving, much more acute symptoms, but it tends to come in flare-ups. So during a flare-up, we're absolutely not going to be massaging or working on those joints. But if someone suffers from rheumatoid arthritis and they're not in a flare-up, then massage, again, being aware of supporting the joints, modifying pressure, can help to relieve some of the symptoms. So ankylosing spondylitis is an inherited autoimmune disease that mostly affects men in their mid-teens to mid-30s. And what happens is that sections of the spine gradually fuse together. So commonly it starts with back pain and stiffness, fatigue, especially around the sacrum, so the very lower back. It may stay there, or it might start to progress up the spine and occasionally affect joints outside of the spine. It can flare up at any time, and there may also be inflammation of the lungs, heart, eyes, and other organs. In acute phases, then absolutely massage is contraindicated wherever there's areas of pain and inflammation. Massage in the early stages of the disease can help maintain some mobility, but be careful about putting pressure on muscles near the spine, as they may be guarding and providing protective splinting to vulnerable areas. If the whole spine has fused in the longer term stages, then massage can help to relax the spinal muscles. Next up is herniated discs, or sometimes known as a slip disc, and this is where we get a compression of a nerve root when a vertebral disc ruptures and part of the contents is displaced onto the spinal cord, or more often onto the nerve root. Note, people sometimes refer to any sharp back pain as a slip disc, but an actual slip disc is very painful and debilitating and would be diagnosed by a medical doctor. In acute stages, refer your client outwards, so to a chiropractor, osteopath, physio. In the non-acute stage, massage might help to relax the associated muscle tensions, but you absolutely need advice and referral from their medical team. So what does this mean for massage? So we've talked about all the joints and all of the motions available in them. Well, massage has been shown, and various research has shown this, that massage can help increase range of motion to help bring it back to original levels. It releases tension in the affected muscles, therefore allowing easier movement and greater movement in joints. Research has also helped shown that it decreases pain and helps to increase grip strength in patients with hand arthritis. Studies show that rheumatoid arthritis pain in the upper limbs can also be reduced by moderate pressure massage. And this comes back to what we talked about in terms of being aware of pressure, being aware of these conditions, and working closely with your client to ensure you're working in the right levels. Also for children, so children suffering from rheumatoid arthritis, massage has really been shown to reduce the pain and also the stress levels and cortisol levels in patients. And finally, in terms of lower back, as we know this is really, really common, massage has been shown to reduce the pain of lower back pain and also to increase range of motion. So absolutely lots we can get involved in from massage therapy. So if you'd like to read some more, here are the references from some of the foundations we've talked about for the pathologies, through our anatomy and physiology books, the General Council to Massage Therapists, and we're also referencing all of those research and studies we've discussed. I hope this has been useful and you have a better understanding of what you'll be able to do for joints as a massage therapist.